Welcome along to the Prevention is the New Cure podcast. We're discussing all things NHS and health related with a political twist. I am Steve Bryan, I'm Member of Parliament, represent Winchester in Hampshire. I'm Chair of the Health and Social Care Select Committee in the House of Commons.
And I'm Helen Stokes-Lampard. I'm a GP in the Midlands, Chair of the National Academy for Social Prescribing, and until quite recently, I was Chair of the Academy of Medical Royal Colleges. Hi, Steve. Good to see you again.
Hi, Helen. Nice to see you. Episode 12, the one with the summer holiday.
Yay, the summer edit. And our happy dozen.
Now, well, you've been on your summer holiday. I am preparing.
Yeah, it's a funny feeling when you take a slightly earlier summer holiday and you see everyone else going off to interesting and exciting places. But you're looking forward to it?
I guess so. Yeah. I mean, we go to Devon, so we stay in this country, and that kind of a throwback to when we had very small children and Monty, who's my dog's brother, Popcorn. And we, why would you ever want to get on a plane with very small children? And we couldn't take the dog, so we sort of started going to Devon. And I used to go there when I was a kid, and we still go there. Basically, we go to the same place, and the photos look exactly the same, but I look a bit fatter and a bit older, and the children look a bit more grown up. That's it, basically.
But I mean, let's hope the weather's good for you, because it's been a bit unpredictable recently. But the forecast in the medium range is a bit better, I think. So fingers crossed.
Well, it's currently blue skies and sunny in Winchester, and it is supposed to get a bit better towards the end of this week and next week, which is blessed relief. And for Winchester, it is really blessed relief, because we have Boomtown Festival here in the constituency at the moment, which I went up to yesterday with my son William, just because it opened today, Wednesday, as we're recording this. It opens today to the public. 62,000 people coming to a field near me. So Winchester this morning was full of campers. Hello, campers.
Hello, that's my line, Steve.
Oh, yeah, of course. You do sound like her, actually. So, yeah, they are all descending on Winchester for their festival. It's called Boomtown Fair.
Boomtown. What sort of music?
Well, if I told you the headliners are the Prodigy and Sister Sledge.
Oh, okay.
But the thing is, the Prodigy guy, Keith from the Prodigy, died last year, and Sister Sledge, I mean, they're not in their first sledge of youth, let's be honest. But most of the music I've never heard of. That is not a reflection on them. It is a reflection on me being almost 50, and it's quite dancey, dancey and trancey.
Okay.
So yeah, we're not talking Elton John and Fleetwood Mac.
Okay, but that's okay. Each to their own, and it'll get people moving. But I mean, great to bring some trade to Winchester, although I'm not sure. Does Winchester need the trade at the moment? Well,
I think that the taxi drivers and all that love it. And so one of the things I was up there actually on the health tip is that they've been very good at Boomtown, and there's a whole issue around health at festivals, and there's a whole issue around drug taking at festivals, and obviously drug taking is not good and it's not legal, but there is drug taking goes on at festivals, and there is something called the Loop, LOOP, which is a charity which basically runs drug testing at festivals. So people can go and take drugs there that they get tested, and it's very controversial, as you can imagine. They operate under very strict Home Office licensing. They're not actually at Boomtown Festival this year, in the sense that they don't have a public facing come and test potential dangerous substances, but they have done that in the past. This time they're doing sort of public awareness, because people have died at festivals from taking bad drugs and out in the sunshine and the heat and dehydration, people taking what they think are enhancement drugs, and they end up being horse tranquilizers, for instance, and people have died from that. So there's a whole issue around health and festivals, which we could talk about one day.
I think we should, actually, because there's so many issues around, there's sexual health and screening, there's drugs, there's also just alcohol, the most prevalent drug that's used at festivals. And I think there is something we could be talking about there as well. So yeah, for a future episode.
They're very good at Boomtown. I mean, they'll love this plug, but they're very good and trying to create sort of mental well-being areas in every bit of the festival where they have campsites. So that basically there's the bowl, the Matterley Bowl, which is where the festival exists in. And then there are the campsites, if you like, are a bit away from there. So you sort of you walk away and it gets quieter and it gets quieter, and then you get to the campsite area and they have sort of mental well-being areas for people to sort of decompress, if you like, from
Yeah.
the music, which is quite, it's quite boom boom,
Tense.
and so boom town. And so that whole issue around mental health and well-being at festivals, it's and as you say, the other issues around sexual health and that, it is, there's a lot to health at festivals, which we could talk about in the future. Anyway, it is episode 12. Last time we had Rebooting the NHS with David Haslam and David Pendleton, the two Davids.
Yeah.
And thanks
David.
thanks to them, we had a really good feedback from them. They were good, weren't they?
They were great. It was a really good, provocative conversation about how we should be rebooting the NHS. We need something a bit radical in the near future, not just same old.
Yeah. So please like the podcast, whichever platform you listen to it on, whether that be Spotify or whatever you do. Please like our podcast because it really helps us and it helps more people find it. What are we going to talk about? We've got a relatively shorter podcast this week just because we don't have any guests because it's August and people are quite rightly taking a break, but we wanted to keep ourselves up there. What's going on in GP world, Helen?
Well, I mean, just very briefly, I think general practice is sort of always changes a bit during the peak summer holidays because we have an influx of visitors. So temporary residents, people who are unwell while they're away from home, seeking temporary residents to get emergency treatment at GP surgery. So we've had a little flurry of that in Lichfield. Mostly with us, I'll be honest with you, we're not a coastal town, so we're not a peak holiday area, but lots of people visiting relatives. And we do have a magnificent cathedral in Lichfield, and we've got the very impressive National Memorial Arboretum at the road and lots of interesting historic stuff. So we get coach tours. And we get families generally. One of the commonest reasons are people with fairly minor things or people who've left medication at home. And actually, if you've left your medication at home, if you can contact your own GP surgery, there is something amazing called the electronic prescribing service. So most people will know by now that in England, you don't touch your paper prescriptions anymore. The whole thing is electronic. From the moment the GP or whatever prescriber issues them, goes electronically through to the pharmacy of your choice where you can collect it. But there's also a system whereby you can pick up a prescription from any registered pharmacy in England. So it requires the GP or whoever to press a certain button to make sure that the prescription is collectible from anywhere, but hugely helpful if you've managed to leave your inhaler behind or something important like that. So, yeah.
Oh, I see, yeah. So I suppose summer season, I suppose you got new faces pitching up at the GP in the consulting rooms and people being unwell and on holiday who are not your registered patients. I guess you probably have that a bit less in Lichfield than I'm going to find down in Devon, where obviously it's a seaside town.
Yeah, the Devon GPs grown every summer. They avoid taking their holidays then because they know the demand is greatest during school holidays than at any other time. But of course, a different type of illnesses, often acute, self-limiting illnesses, sort of stomach bugs, infections, and minor injuries. And of course, remembering to use the right NHS resource. So whether that's a pharmacy, whether that's a minor injury walk-in centre or an NHS 111 centre. So think before you pitch up at a GP surgery, is this the right place for me to be? Our local pharmacies are fantastic for a lot of minor ailments nowadays.
Yeah, right. Okay, well, flip-flops to the ready. And I'm actually doing my summer tour at the moment, which is something where a lot of MPs do it, where I rock up in supermarkets and on street corners and hold a little pop-up surgery. I call it my summer tour. We haven't been very summery at the moment. The best one we did was inside the big Tesco's in Winchester, which was nice and dry and actually warm.
Which supermarkets are available, Steve.
Yeah, exactly. Yeah. Although, Sainsbury's let me in. Waitrose don't. Just saying. So yeah, but the weather's been very disappointing for me. Anyway, stories. What stories have we got, Mom?
What about starting with weight loss? That's been a big one today.
Yes. What are you suggesting?
So, I'm absolutely not. Don't take it personally. Don't be sensitive. No, we talk a lot about weight loss when it comes to prevention. We know that for the vast majority of people, losing a bit of weight is incredibly helpful for them in terms of reducing cardiovascular stress. And it's a weight loss drug story today. So you may recall a few months ago, a weight loss drug was approved for use in the NHS. I think it was about June approval came through. Turns out this same drug, that's Wegovy, is it ringing bells with you?
Yep, I heard it.
Yeah, proper name semaglutide, has been shown it cuts the risk of a cardiovascular event in overweight people who've got heart disease by a fifth. So basically, 20% reduction in risks of a heart attack, essentially, if you're taking it compared to not taking it if you're overweight. So we need to see the proper research paper. One of the frustrations I think we've mentioned before is, for me as an academic, is seeing big research findings presented by press release as opposed to in peer-reviewed research paper. But of course, something like this is going to push the share price of a drug app, so they have to release them very carefully this way. Any thoughts on this, Steve?
Well, I mean, obviously, yeah, obesity and the health impacts of it. I think that we often quote the figure, and it's probably underquoting it. It costs the NHS about £6 billion a year. Wow. So, these are big figures. I think this injection, the Wegovy injection that we're talking about, I think it's very popular in the US, isn't it? And I guess my only concern would be the messaging around it, that it's not a replacement for healthy eating, for good exercise, for understanding any other reasons for weight gain or weight loss. Is that there's no such thing as a magic pill, and there's no such thing as a magic jab. And if something seems too good to be true, it usually is. So I guess while the makers would say there's a clear medical benefit to this, there's just that warning light. Would I be too careful in saying that?
I think that's absolutely spot on, because the challenge here is that we medicalize stuff that should be behavioral. But seeing this as a supplement, not as a replacement for healthy living, exercise, good diet, and obviously the hard discipline that comes around losing weight. But I think I've certainly seen huge benefits in patients who've used it. Remember, this was a drug originally developed for use in people with the management of diabetes. Then the weight loss benefits was so striking in some people who were motivated already with diabetes. And then the additional trials have been done. It's been used in weight loss clinics in the UK for quite a long time. And I think one of my worries is that when people can access drugs like this privately, you create a greater divide between those who can afford to pay for stuff privately versus those who can't. But I think, and the other thing we know is that in some of the earlier trials, certainly when people stopped using it, the weights crept back on again. Well, that's not a long-term solution. We can't have people on self-injectable, expensive, very expensive drugs lifelong. That's not going to be right for society. So there is something about working out how best they can use to fit with the NHS model, definitely our prevention agenda, but as part of a full lifestyle package, not just drugs with a solution.
And it's worth saying that Novo Nordisk, who are the makers behind this, they say they're going to take it to regulators in the US and the EU before the end of this year. It also going to need to be approved by regulators here in the UK, so the MHRA, and then of course it would have to be decided whether it could be offered on the NHS beyond the use that it currently has. So there is some way to go on this, but anything that can help us tackle the obesity challenge and its impact on poor health and the prevention thereof obviously is something that we're interested in. Go on.
Sorry, can I give a quick plug for NICE, the National Institute of Clinical Excellence? Because we're so lucky in the UK, we've got an independent body who take the findings. So the MHRA may well license this, but then there's the question of whether this is a cost-effective, appropriate thing for the NHS to be funding, and that's where NICE comes in. And I think we are very fortunate in having a body that can take an objective look at these things. Certainly, you'll always get lobby groups and pressure groups pushing hard for what they want as an outcome, but they're looking what's best for the whole of society. And I think it's not to be underestimated. And they're really looking to fast track their decision making. They've really had a big overhaul the last year or so. So it'll be interesting to see how they respond to when this comes through next year.
Yeah, and they're going to face more and more of these challenges as more and more drugs come online, which has been their challenge for many years. Tell you a story that really caught my eye as a former health minister, and I had the international brief, and I really loved that and got a chance to travel to G7 and G20 meetings. Is this, it's often the way, isn't it? The apple fell from the tree and landed on the head. Chance discovery helps fight against malaria. Malaria kills about 600,000 people a year, which, often children under 5, which is just heartbreaking, isn't it? And vaccines, of course, have been developed, but they're still in the early stages being rolled out in Africa. I think the stat is that in Africa, malaria kills a child every single minute. But I know, and a credit to people like Bill Gates, the foundation, who've done so much to help in this space. But There's been some new data I spotted published in Science magazine suggests that the bacteria can reduce a mosquito's parasite load by up to 73%. They found a naturally occurring strain of bacteria which can help stop the transmission of malaria from mosquitoes to human. They found it by chance after a colony of mosquitoes in one experiment didn't develop the malaria parasite, which they then pass on to often children. So this is a really interesting story, isn't it?
Fab. It reminds me of the first chance discoveries of penicillin, sort of mold in Petri dishes. And it was only the next morning, looking back at it, that past, that they would just sort of hang on. What's just happened? It's that chance observation, and not overlooking a chance observation, but actually having the scientific curiosity to pursue it, and which is what seems to have happened here. So it looks like they've been looking at this for quite some time, because the observation was first made in 2014, then went back a couple of years later. So it was 2016 they first noted, and then they've been interrogating it properly since. So I think this is exciting. And if you can reduce the viral load, you reduce the amount of disease transmitted. It's straightforward. So yeah, very exciting. One to watch.
Yeah, I have a bit to do with a charity called Malaria No More,
Oh, do you?
who've definitely been in touch with the select committee, a really good bunch of people.
Good.
And they said that it was promising. The chap called Gareth Jenkins, who was did some media on this when this story came out the other day, said malaria kills a child every minute. Significant progress has been made in reducing the global burden of malaria. But to get us back on track, we need new and innovative tools in the arsenal. And with a strong innovation pipeline, it's possible to end the threat of malaria in our lifetime. So wow.
Amazing.
Wow.
Yeah.
It really would. It really would.
Not a huge problem in the UK, but you do get cases every year of people coming back, mostly traveling abroad and then bringing malaria back with them. So yeah, wonderful if we can do that.
So there's an old disease, and then a relatively new disease is something that seems to be back in the news a little bit, and it keeps coming up anecdotally. Be interested to know whether it does in your world. Is COVID-19?
The minor matter of the global pandemic, COVID-19?
Yeah.
Yes, the pandemic formerly known as. Yeah, it's definitely around. It's not gone away. Never went away, Steve.
And it's back in the news because COVID vaccines are not going to be offered routinely to healthy under 65s this winter, following information that governments have received from the immunisation experts, the Joint Committee on Vaccination and Immunisation, the JCVI. Last year, all over 50s, which is happily not me, were invited for a booster jab. Not yet, anyway. We're invited for a booster jab, but only the 65s are going to get the option this year, and the government have accepted that advice. Now, from a clinical point of view, doctor, do you concur?
It's a really interesting one. So I'm a huge fan, a proponent of vaccines, both influenza and the COVID vaccine. And if you remember, the first big rollout, the evergreen vaccination offer for COVID was that everybody should be vaccinated. Then we defaulted to the sort of the booster being everybody over 50, plus those with plus young children, plus those with a poor immune system or in a disease group. The fact now we've reverted to effectively what used to be the flu vaccine target groups prior to the pandemic is essentially what's happened here. So COVID is being treated like influenza in terms of the vaccine. It certainly raised a few eyebrows, because there are people who are thinking, actually, I want the protection. I don't want to have flu or COVID, even if I only get them mildly. They're really stinking, miserable infections. In fact, I've had a few patients just this week who said they've had COVID, or family members have had COVID recently, and how miserable they felt, and they'd forgotten what a miserable virus it is. But I think there is also a balancing act. And obviously JCVI, who are extremely wise, have looked at all the evidence of the benefit to wider society versus the cost of rolling out vaccine, and come up with this. And I've never argued with what the JCVI have come up with in the past. I'm not about to now, but I'll be interested to learn more about it, because I've heard grumblings. I think that's fair to say.
Well, do you remember how many times did we hear this during the pandemic when ministers said, and the NHS said, we will follow the evidence, will be led by the science. Do you remember that term?
Absolutely.
And this is the science that is telling ministers do not make these decisions without advice. They have to accept advice or reject advice. And if they do either, they have to justify that. I used to receive advice from JCVI, and it's a very brave minister or a very well briefed to the contrary minister who decides to reject that advice. So yeah, I can't deny I've had a few constituents contact me and complain about this, but I think the science, and JCVI, of course, publish all of their deliberations, is very clear on that. It does seem to be, I've met a few people in the last few days who've sort of said to me that they had COVID last week, and there seems to be a pretty nasty bout of it going around at the moment. And this is mid-August. Should this worry us? Or, I mean, is it just the same way as, there's a nasty strain of a cold goes round, or flu will go round?
Well, what's interesting is normally respiratory viruses peak in the winter months. So we're used to a massive spike in January is the commonest month for influenza, the peak. Although it can start early. I mean, the year just gone, it started in December. Actually, COVID hasn't followed that trajectory. So COVID is behaving differently from influenza. And certainly, as I said, I've had a couple of patients this week who've known people or family members who've had it. And of course, many people aren't testing anymore. So it's going to be circulating. We're just going to know. There've certainly been lots of people with very annoying chesty coughs, which drag on for weeks and weeks and weeks and weeks. The cough, I mean, not feeling unwell. And that, I find myself with my sort of medical antenna going, I wonder if that was COVID that they've just had, just because of the longevity of the symptoms and how washed out people have been. But this is all about learning to live with the disease. And I think the new normal is that we're going to have these infections. Finding a new pattern, Steve.
But why would you test? Because you can't report it. There's nowhere to go with it.
Exactly. There's no means of reporting. I guess for me, at a personal level, I'd be thinking about the most vulnerable people I work with and the high level of infectivity of it. So, as a healthcare professional, would you want to come and see lovely Dr. Helen when she's hiding behind a mask but is coughing and spluttering, but feels well enough to go into work? Now, I have to say, there's a real balance here about, I think we've all changed our tolerance for being in work when we're not unwell. And there's a whole thing about presenteeism and people soldiering on into work, which I think has reduced a lot because of the pandemic, because we're better, certainly in the surgery, at looking at one another and going, much as I desperately want you, my fellow GP, working alongside me today, you look rubbish, you sound rubbish, and you're going to scare the patients off, and you look like you need to be at home in bed.
Oh, well, do you remember when Matt Hancock was before my select committee, when Jeremy was chairing it during the pandemic? And I remember him saying, in the future, we may have to get more savvy about people who've got colds, viruses, sniffles, working from home, because we then stop it circulating. Exactly. And a lot of people sort of poo-pooed that at the time, but I think, I don't think that's government policy. I think it needs to be, but that is what's happening, particularly in the public sector. I hear that from a lot of people who say, I was speaking to somebody the other day who works in a local council, who was saying, that they'll often have a hybrid meeting is now the norm, because there's always somebody who is not quite right. Now, but of course, if you're an employer, you've got to make sure that's not abused, though, haven't you?
There's a balancing act here, but I mean, there's so much you can do to monitor people's work rates and so on when they're working at home. But I think if you're off sick, should be the first thing as a doctor. You need to rest and recuperate. I think it's when people are recovering from infection, they feel they're able to perform at a reasonable level, but they're still coughing and spluttering. So I had a chest infection 6 weeks ago and I coughed. Well, actually, it was 8 weeks ago. I only stopped coughing 2 weeks ago, intermittently. But for that week or two after the infection, where I was still having horrible paroxysms of coughing, but, I felt otherwise fine. I was conscious that if I was out and about traveling, people looked at me like I was a social pariah, and people didn't want to be around me. So I think society has changed. None of this is going to be helped by the vaccination changes, but I think it is a separate but important conversation about prevention. How do we better prevent respiratory diseases going forward, and what will the new societal norms be?
Okay, let's take a quick break, and then we're going to talk about NHS workforce and Down Under. Welcome back. I said we're going to talk about Down Under, Helen, and the NHS workforce. So I'll tell you why. Nick Triggle, who's BBC reporter, and a good one, has done a piece of work, which has been published online today, which analysis of data suggests that this claim that there's an exodus of doctors going down under, and of course it's one of the reasons put forward to support some of the industrial action that's gone on, is not borne out by the facts. So what he's done with some colleagues, Rob England, Jim Reed, they've done quite a bit of work. They've looked at data from NHS Digital in England over the past decade. And the way that they do it is by looking at what they call the percentage of doctors who are applying for certificate of good standing,
Yes.
which is something that they would allow them to, I guess, to go and apply for positions overseas. Now, applying for a certificate does not necessarily mean that the doctor went on to leave the country. And the reason I know a little bit about this is I remember being at Department of Health when Jeremy Hunt was health secretary in the first junior doctor strike when I was his PPS. This was 2016.
Yeah.
And there was a lot of stories then about this. Oh, they're all off. They're all leaving. And of course, there were lots of people downloading said certificate, but doesn't necessarily mean that they use them. And Nick's piece of work seems to suggest that that is still the case. I'm not being triumphant here at all. No reason to be, but I think it's sometimes important, isn't it, to not let the facts get in the way of a good story.
Yeah, or a good headline. I mean, I think, I mean, a lot of us will have been slightly horrified by the sight of Australia medical bodies recruiting for jobs down under by putting billboards alongside junior doctors who are taking industrial action. I have to say that left a bitter taste in my mouth. But you can see why it happens. But this piece of work is really interesting. And I think they've tried to do it very well in a balanced way because they've got the NHS digital data and they've got GMC data. And they've really tried to find the truth behind how many doctors are leaving the NHS and how many are joining the NHS. And certainly their consensus is more are joining than are leaving. So the overall numbers of doctors are going up, which is a good thing. Goodness knows we need them. But I think there are nuances within this data, Steve, that we shouldn't overlook. That there's a huge number of doctors in their earlier stages of training who are deferring going into substantive training posts. A lot of them do come back, but they're pausing training, and which is meaning they are having time to think, to recover, and to regroup. There's definitely a lot of bitterness out there on the front line. So I think whilst this headline may be reassuring for people planning the workforce, I wouldn't get too complacent on the basis of it, because I think there's depth and there's nuance within the data that could be overlooked by the headline.
Yeah. So in 2022, I think it looks like what I can see from the data here is that we're just under 7,000 doctors seeking this certificate of good standing. And if you go back to, 2016, it's a bit lower than that. And just when you get to the original protest, the junior doctor strike, it was over 8,000. Where those certificates were requested. So the numbers go up and down. People can look online, but you're right. Of course, going abroad is still an option, isn't it? And it's a nice option. There are all sorts of lifestyle reasons, health reasons, family reasons, mental health reasons why people might want to go and work in Australia. I mean, it's not a panacea. Australia and New Zealand are not UK, and it's not where you're from. But of course, Australia is an attractive destination for doctors. I understand that. But then you know what? So is the NHS, and so is the NHS pension scheme, and so is all the wonderful things about the varied country that we live in here, with the varied weather pattern that we have, which I know we moan about, but it's boring if it rains all the time. But it's also, I think it's boring if it's just sunny all the time. I think this is a fantastic country to live and work in.
Yeah, I mean, just to finish up on the junior doctors bit of it. I mean, there were over 12,000 doctors who were trained abroad who joined the medical register in the UK last year, whereas homegrown doctors, newly qualified homegrown ones, 8,000 joined the register. So more overseas doctors are joining the register than UK trained doctors. I think that's quite a powerful statistic, because those who are leaving are being replaced by those who come in from overseas, and some.
Okay. Yeah. So if you're interested in that story, I think you just sort of Google UK doctor exodus and you'll see that piece of work that Nick Triggle and his colleagues have done on the BBC. Okay, right. It's time for me to press this button, Helen. Ready?
Oh, that makes me happy, Steve.
Does that make you happy? Because that means
does.
the pod surgery is open with my 1970s doorbell.
The infamous now 1970s doorbell.
Yeah, here's one that you will be interested in from somebody called Steve Hathaway. Hello, Steve and Helen. We have been into prevention throughout COVID by monitoring for high temperature, as this is an initial and primary indicator of early stage infection. By isolating a medical diagnosis, the infection is therefore contained and prevented from spreading to others. So, what we were just talking about then with COVID. Has the NHS done any specific research to investigate using temperature monitoring for wellness and general prevention. So I don't know what the answer to this in terms of the research that they've done, but from a clinical point of view, I mean, he's right, isn't he? That temperature and monitoring that can well be a useful sign of ill health before it becomes serious.
Yeah, it is interesting. I mean, I certainly don't know in terms of the research side of it. I'm quite sure there are researchers out there now who will write in and let us know what work is being done on it. But at a practical level, I mean, keeping an eye on your temperature, knowing what your baseline temperature is, having a reasonably sensitive temperature measuring device available at home are all really good things, because you know when it goes up, that's often a sign your body's fighting an infection. I mean, from my point of view, the times when it is used most are for people who are immunocompromised, so those going through chemotherapy, those who've got very poor, perhaps renal function, on transplant lists. They are often people who are strongly advised by secondary care specialists to keep a close eye on their temperature and use that as an indicator to contact us as their GP for early interventions with antibiotics and so on. But also, for me, it's a contraception use is patients who closely monitor their cyclical temperature for an ovulation prediction. And you need a good fine reading thermometer to do that. So certainly our natural rhythms and temperature measurement is fascinating. It's certainly not a recommended for everybody yet, but I'm sure research will emerge. I'm keen to know more.
Very good. Anyway, what have you got?
I've got one from Paul in the Midlands, who has asked, dear Steve and Helen, please can we hear more about Monty? He's the most interesting part of the pod some week.
I'm not sure whether we should be grateful or insulted.
I think
Monty,
it was a tongue-in-cheek request.
Yes, Monty is my black Labrador, who is, because I'm recording it at home during parliamentary recess, is currently at my feet, but he's in disgrace. He is in disgrace, Helen. Well, yes, because we're playing a bit of golf and he comes on the golf course with me. And what he does is he seems to have some kind of a homing device for water. And any of you who play golf, who listen to this, will know that sometimes the water on golf courses and water features on golf courses are not designed for swimming in by humans or dogs. They are filthy and they stink. And so the other day, I was playing at Dulwich Golf Course. He found some water, which he decided to jump into with gusto, and then ran onto the green and shook himself all over the white trousers of the partner I was playing with, who took it very well, and exceptionally well, considering I went on to beat him. But yes. Bless him. He is in disgrace about this at the moment when we go to the next golf course. But other than that, he is in fine form.
So, which brings me to you do a lot of walking with Monty. I mean, he ensures you do lots of walking. So
4.5 hour walk when he comes on the golf course.
Do you manage your steps, Steve? Do you wear a step monitor or
no? Never, and I should.
Yeah, I mean, you probably give yourself a really good, smug boost by. So I've got one of these smartwatches I've had step counters and smartwatches and things over the years, because there's something for me. I'm inherently slightly competitive. But mostly personally competitive, and it's about how I can sort of do better. And I like the sort of the gamified element of counting my steps to see if I can fit extra steps in on a day when I've been a bit inactive. So I know surgery days, I have to get up and call the patients in from the consulting room, and the building I work in is quite large, but I really struggle to get a decent number of steps in a day. And I have been known, this is an embarrassing confession, but I have been known as it's getting close to bedtime to looking at my step count, realizing I'm a few hundred short of the daily target, and going for a walk around the garden, around the house, or a few trips up and down the stairs. My husband is normally sitting there chuckling away to himself at my neurosis. But today I've spotted a story about steps. Have you seen this one?
No, go on.
There's been a target, it's been touted that it's 10,000 steps a day we need to be taking, the magic number to stay fit and healthy. But a new study has shown that less than 5,000 steps may be sufficient to see benefit. So there's a big global study being done. And actually, just over about 2,500 steps a day is enough to have benefit on your heart and blood vessels. And then for every extra 1,000 steps you do reduces the risk of dying up to 20,000 steps a day. So you're going to be up to 20,000 steps and if you're doing very long walks with Monty. But me and my GP colleagues who are in surgery who's struggling to get to 5,000 steps a day can be a little bit reassured that actually, as long as we do get up and go and get the patient into the consulting room, make sure we, get the walks and exercise in when we can, it's not as bad as we feared. And there's some really interesting work about how we understanding that the calories on the energy that we expend that isn't necessarily on formal exercise, but that is doing the normal thing, whether it's the housework, it's the ironing, it's the clean, whatever, is all useful for our cardiovascular health.
Okay, yeah, I see you sent me the link now. So if people want to find out more about this, it's the Medical University of Lodz in Poland and Johns Hopkins University, a School of Medicine in the US, where you can find out that piece of work.
So I thought we should wrap up with some final holiday conversations, Steve, as you're about. So tell me, flip-flops. Are you a flip-flop man?
Good Lord, no. No, I have issues with things between my toes.
Toe post.
And flip-flops. I mean, I don't like anybody touching my toes, let alone putting things between my toes. And I can't imagine, therefore, why you would put something on your foot that is a permanent toe toucher. There's obviously a huge psychological unpacking that needs here, a lot of issues. Yes, doctor, but I can't think why you'd want to put something between your toes. So William, my son, has just bought some sliders, which I'm quite taken with. Monty was quite taken with them and in fact took them, but they were retrieved quickly. But yeah, I'm quite keen on the old slider.
Yeah, sliders are a great option, and then you've got the sort of sandals with straps over them. I mean, flip-flops certainly provoke quite violent reactions in people. So, I mean, I have to say, I like a toe post so long as it's a soft cushion toe post. Can't be doing with those nasty hard plastic toe posts. So, I'm with you there. But there are some nice ones with a cushion toe post, which are worth a try. Sliders are available. Which brings us on to sun hats, Steve.
Right.
Floppy rim, bucket hat, baseball cap. How'd you keep the sun off your face and head? Spurs
baseball cap.
But okay, fair enough. Okay, that's
someone's got to wear it.
Well, I'm a cricket fan, and I quite like seeing the sort of the large, proper floppy cricket hats.
Oh, right, a Tilly hat, yeah.
Yeah. Although I have to say, last weekend we were meant to be at the 100 in Edgbaston with some friends, and it was a complete washout. So we sat at home, which was very disappointing. But
my father-in-law used to have a Tilly hat, and we went on holiday once when I first met my wife to a hot part of the south of France, and we couldn't find him, and he was sitting in a cupboard wearing his Tilly hat, reading a book, which I know you were going to talk about sun cream, and which is probably the safest place to be if it's really, really hot. It was a bit weird, but he certainly didn't get sunburn, I can tell you that.
Yeah, well, I did want to finally finish with sun cream because of, this is all about prevention, this podcast after all. And it amazes me how many people still won't use adequate amounts of sun cream and appropriate amounts of sun cream. So even though you are, in your words, just going to Devon is very wonderful. Have you got the sun cream ready? And what sort of, are you a sun cream or a sun spray, the alcohol-based one?
I don't know. I mean, I don't like creams.
Right.
So, like Susie will often say, if I've got dry hands, put some hand cream on. I cannot bear slimy hands. And for me, sun cream is just part of that. But don't panic, doctor. I get it that I need to spray the stuff and rub it in. So yeah, I'll wear sun cream for you, I promise.
But the liquid, and I think this is a really important plug, is that there are liquid-based ones that are not leaving you greasy and sticky like the creamy ones. I mean, the creamy ones are easier for getting a high factor coverage. So certainly for kids and people who need that factor 30, 50 or whatever. But for the sort of lower factors, the liquid ones are actually really good and well absorbed. So give it a try. Protect yourself and save yourself from skin cancer down the line.
Yes, boss. Okay, should we wrap it up there? A couple of things for the future is that we have just launched on the Select Committee a new inquiry on men's health. Which is the first time a specific men's health inquiry has been done by a parliamentary committee for a long, long time, certainly the decade or more that I've been in Parliament so far. So we're doing that, which people will be interested in. And I did a big talk with something called the Men's Health Forum the other day to launch the inquiry. Yeah, to launch the inquiry, and being contacted by quite a few very interesting organisations wanting to come on the podcast and talk about that. So I thought we could do a men's health special at some point. I'm hoping we're going to still talk about food intolerances, and there's a really interesting family family who've got a tragic story to tell, and I'll let them tell it when they come on about they lost their brother and son to a food intolerance a few years ago. They're going to come on and talk about that. And Secretary of State has confirmed some time to come on. So we'll probably be doing that, talking to the Secretary of State on the podcast in September.
Excellent. Looking forward to it very much. Have a lovely holiday, Steve. You've earned it.
Thanks so much, Helen. If you want to contact us, you can find us on social media, LinkedIn, Facebook, Twitter, or X, or whatever he calls it this week. You can find us on there, and podcast at stevebryan.com will reach us with questions and subjects for pod surgery. Until next time, see you soon.
Bye.
Bye.